Hello friends, this is Dr. Manish Soni, and today let us discuss about anogenital warts. So these anogenital warts are commonly caused by human papilloma virus. So human papilloma virus, commonly the subtype 6 and 11, and if we see among these, 6 is more common than 11 and less frequently by subtypes 16 and 18. So the causative agent is human papilloma virus 6 and 11. Now this anogenital warts is commonly seen in the age group that is 16 to 24. So you can see young males and females are commonly involved, and if you see the sex predisposition, the incidences are more in males in comparison to females, that is in the ratio of 1:0.7. Now let us talk about the clinical features. So these anogenital warts, they present with asymptomatic, soft, pink, elongated, and sometimes they can be filiform or pedunculated growths, commonly over the wet surface. Like you can see in this picture. Now this is a patient who is suffering from anogenital wart, and in this picture you can see these growths have come up over the genital area. So these are asymptomatic, soft, pink colored, elongated growths which are present. Sometimes they can be sessile or pedunculated or filiform, okay, and they generally involve the wet surface. Like you can see the glans penis is being involved here. Now the common sites, if you see the common site for anogenital wart in males is commonly frenulum. So frenulum is commonly involved, then corona is involved, glans can be involved, while in females posterior fourchette is commonly involved. So these are the common sites for anogenital warts. Okay, so these anogenital warts which are present, as you can see in this image, they are also known as Condyloma acuminata. Condyloma acuminata. So this is a case or image of Condyloma acuminata which is commonly seen. Then there is one more type. As you can see, this is again a case of anogenital warts. Here the lesions, same asymptomatic, soft pink colored lesions, they are present over perianal area. So this is again a case of Condyloma acuminata. Then in this image, this is a case of bovinoid papillosis. So bovinoid papillosis is nothing, it is papillar anogenital wart. So when such papillar lesions are seen, okay, so such papillar anogenital wart is also known as bovinoid papillosis, okay. And sometimes these growth may become very large. As you can see here, this growth is very bulky, large, cauliflower like growth. So these giant growths or these giant anogenital warts, they are known as Buschke-Lowenstein tumor. So this is an image of Buschke-Lowenstein tumor, which is large or giant anogenital wart. Now if you do the histology in this case, so if you do histology, you'll find coelocytes. So coelocytes are seen. Now what are coelocytes? Coelocytes are nothing. These are the epithelial cells, that is, these are squamous epithelial cells like keratinocytes, which has undergone various structural changes. Like you can see that these epithelial cells or keratinocytes, they present with nuclear enlargement. So nucleus is large. Then other structural change like irregular nuclear membrane. So irregular nuclear membrane. Then hyperchromasia. Hyperchromasia, that is, they appear dark. And last one, that is perinuclear halo. So these structural changes are seen, and these nucleus, they appear pycnotic. So such changes which are seen in these epithelial cells give rise to these coelocytes. So coelocytes are seen on histology of anogenital warts. Now most of these warts, they spontaneously resolve. So if you see the course of this disease, most of them they spontaneously resolve, while very infrequently they might lead to malignant transformation. So most of the cases they spontaneously resolve, but very rarely they might lead to malignant transformation. Okay, and malignant transformation is common with the subtypes 16 and 18. As I told you, they are commonly caused by 6 and 11, okay, which generally do not lead to malignant transformation. It is commonly if there is causative agent, that is 16 and 18. So when malignant transformation occur, it might lead to anogenital squamous atypia, or invasive carcinoma. Now the chances of this oncogenic potential is more if this patient of anogenital wart is also associated with HIV infection. So if there is HIV association, there are more chances of this malignant transformation. Now how you will treat this patient? So treatment, there are various modalities which can be used in treatment, and treatment can be provided by you, that is the doctor. So if the provider is applying something that is provider administered, and there are few things which can be given to the patient so that they can apply themselves, so they can be patient administered. So if you are applying over the lesion, then generally we prefer podophyllin. So podophyllin application can be done. So 25% podophyllin is available, and there is a purified form of podophyllin, which is known as podophyllitoxin, 0.5%. So these two modalities can be used, that is podophyllin or the purified form of podophyllin, podophyllitoxin. Podophyllitoxin is patient administered, while podophyllin is provider administered. Now here you need to remember few things, like what is the mechanism of action. So mechanism of action for these is anti-mitotic. So these are anti-mitotic. Now for Podophyllin we do once a week application. So these are topical agents. We apply over the lesion once a week and then ask the patient to wash the lesions after 4 hours. While in podophylotoxin, we ask the patient to apply 3 days in a week. So we ask the patient to apply for 3 consecutive days in a week, twice daily. So twice daily, and then wash these after 8 to 12 hours. So here we apply for 4 hours and then wash, and here we apply for 8 to 12 hours and then wash. Generally what we do, that if this is the lesion, we first apply petroleum jelly around the lesion. So over this portion around the lesion we apply petroleum jelly, and then we apply this podophyllin over the lesion. Okay, so this helps in protecting the surrounding skin. Okay, and this topical agent is only limited to the viral wart lesion. So this was the first thing which you can do. Then second thing, that is provider administered, is you can apply trichloroacetic acid. So trichloroacetic acid in the strength of 50 to 100% can be applied over the lesions. And third thing which is provider administered is cryotherapy. So you can do cryotherapy. So both these, that is TCA and cryotherapy, they are safe in pregnancy, while podophyllin is teratogenic. So podophyllin and podophylotoxin should be avoided in pregnancy. Now for patient administered, second thing is imiquimod. So you can ask the patient to apply imiquimod, which is available in 5% cream. So you can ask the patient to apply imiquimod. It is generally applied 3 times per week daily. So 3 times per week daily, and this has to be continued for 6 to 10 hours. So you need to leave it for 6 to 10 hours at bedtime, and you need to continue for at least 16 weeks. So for 16 weeks, 3 times a week, you need to apply this. And the mechanism of action, if you talk about the mechanism of action of imiquimod, it is immunomodulator. It is immunomodulator. It actually acts on toll-like receptor 7 and 8. So this is all about anogenital warts, and recently there was a question in November AIMS 2016 on anogenital warts. So these points will help you answer such questions correctly. Thank you very much.